testosterone today, and hopefully we are welcoming on Dr Anna Cantlay, who is a GP. She works within the NHS and privately, and she specialises in now I'm going to just get her straight on and we can get on with it. Are we there? Let's see if I can get her on. Here we go. Here we go. Boom.
Hey, hello.
Hi, Anna. How are you doing?
I'm really well, thank you. How are you?
I'm very good. Now, I know that we've only got you for a really short time because you're in clinic today.
I am, yes. I'm in my NHS clinic, so I've dedicated my lunch break to you. So hopefully we can get to as much as we can.
That's very, very kind. I'm just going to turn my volume up. Now, listen, do you want to... Now, let me just start again. If you have not come across Dr. Anna Hormones, it's important that you follow her because you are a menopause specialist amongst many other things, and you have the most impressive feed full of information, and also your website and everything else. It's a great resource.
Oh, thank you.
So we're talking today about testosterone, and we may as well dive on because we've got you for such a short time. Now, just for fun, I put into Google this morning, what is testosterone?
Oh,
and now well, it sets us off on a certain sort of slant in that we're all quite confused about testosterone. And no wonder, because when I put it in, it says testosterone is a hormone that plays a key part in development and function of the male reproductive system. It goes on for 2 pages of information about testosterone, which doesn't mention females. It mentions their prostate, their testicles, and that testosterone varies and will naturally decrease in age for men.
Right, yeah, very little mention of women, but it's such an important hormone for women as well. So if we go back to the beginning, where do we produce testosterone? So it's one of our sex hormones. It's produced in our ovaries. It's produced by our adrenal glands, which are little glands that sit on top of our kidneys. It's also really interesting, produced in our peripheral tissue, so things like our fat, by a process called aromatization, where actually estrogen can get converted to testosterone and vice versa. And there's really exciting and interesting research happening around testosterone in the brain at the moment. And we actually think that testosterone production can happen in the brain as well. So our brain cells can actually be responsible for producing bit of testosterone, which we call a neurosteroid. So it's a really fascinating female hormone. And actually, in like for like, in the premenopausal woman, actually we produce testosterone at a similar sort of rate to estrogen. So it's an essential female sex hormone with lots of different effects on the body. As we age, sort of peaks in our 20s and 30s, and then we do start to see an age-related decline. There's a little bit of a decline, obviously, when we go through menopause, as our ovaries are producing less sex steroid hormones. But from a testosterone point of view, the ovaries are still hormonally active post-menopausally and will be producing a little bit, but it won't be at the same levels as sort of premenopausal levels. And what's really interesting, which not many people know about, is that we're seeing actually around the age of 70, so between age 70 to 80, we suddenly get another little spike again of testosterone. We don't really understand why, but it is, if you look at levels in the blood, there's another little spike again in later life. So isn't that interesting? We don't really know why, but this is the beauty of women's health. There's hardly any research, is there? So all of this is stuff that we're trying to work out at the moment. So yeah, really, really important hormone. And we've got a bit like a kind of lock and key. Testosterone will fit into lots of different receptors around the body, which we call androgen receptors. So it's really well known for being responsible for reproductive and sexual function. So we know that in women, it can help with sexual arousal, sexual desire. It can help with orgasm. And that's probably its more well-known role for women. But it has other roles in the body. So it's important in musculoskeletal health, in our bone health, in our muscle function. We know it probably plays a role in the health of our genitalia, and also in the mind. So there are lots of androgen receptors in the brain. So we think it's probably very important for sort of brain health as well as things like heart health. But again, such an under-researched area, and we need a lot more research to really understand its role and the role of testosterone replacement in women. So yeah, watch this space. Hopefully, lots more coming soon.
So it's very much a female hormone. So
Absolutely.
that's the first thing for us all to know. It's also a female hormone. So should probably be on this document
We
somewhere.
need to get that changed.
So just for the average woman, because it feels to me like the testosterone conversation is a similar sort of level to people sort of whispering about HRT some years ago. We are sort of saying, have you got it? I've got some. Have you got some? No, I haven't got any. Do I need it? Should I have it? We don't really know where to start with it. And it seems that on the NHS, it's not necessarily encouraged unless it's under very specific situations or circumstances. Where do we start when we know we're in menopause, perimenopause, to have this conversation with our GP or anybody?
So I think firstly, what a shame that there still seems to be a taboo about it, because it's in the NICE guidelines as an option for women who are experiencing menopausal symptoms. The main reason we would prescribe it according to NICE is for women who have distressing low libido. So not just low libido that's not bothering you, it has to be distressing, which again, you know, you can talk all day about that definition, but the medical term we would use is hypersexual desire disorder.
Yeah.
Which is actually in the American psychiatric definition disorders. So normally where we would be looking to prescribe it is for women who are already established on hormonal replacement therapy in the form of estrogen and a progestogen if you've got a womb. And they're still struggling with libido, they're still struggling, you know, with desire. And so we might add it on additionally for that purpose. Where we see some other areas of interest, and again, there's a really encouraging to see that there has been funding approved for a randomized control trial, looking at around 400 women, looking at other outcomes in menopausal symptoms. So observationally, women often do report other benefits. So things like cognitive function, kind of motivation, brain fog, muscle aches and pains, energy. But the data is lagging behind those other areas. And so we really need more good quality randomized control trials to be able to say, yeah, we definitely know that that's not a placebo effect, that this is actually going to add value for those other symptoms as well. And I think,
So
sorry, carry on.
is that the test, the research that you're referring to, is that the testosterone patch that is coming out of King's?
No, this is the ESTEEM trial. So it's newly announced over the last few weeks. So I think it's a trial that's going to be happening near Wales. Yes, there is data around a testosterone patch. We don't have a patch on the market at the moment. So again, we welcome that research as well. The more products we have available, the better. And ideally, if we can get some products to market that are actually for women, because as you know, at the moment in the UK, we're having to use male products off label, off license at lower female doses.
Yes.
So, you know, that in itself is a big inequality, and something that needs to change.
Yes, and I would love to get into that, because I know that I was given this lovely little tube, which was great. It had a cap on, and then after that, given sachets that were sort of, you've got to splurge a bit out and then have it hanging around on your basin. But let's come to that. So Anna, how do I know if I need it? How do I even know? Because I'm having conversations with my girlfriends saying, do you need it? Well, I think I need it. Well, I don't know if I need it. Well, I don't know. Shall I try and get it? How do we know? Can we ask for a test?
Yes, you can, but the main reason we do testing is not to identify a deficient level. We're mainly testing to check that if we were going to start, that your levels that you're producing internally, endogenously, are within a normal range, that you're not up at the higher end of normal, so that we don't tip you over into being what we call supraphysiological in your levels. So really what we're going on is your clinical symptoms. So if you're a woman that's been on HRT at a good dose for a good few months, so 3 to 6 months, and you feel, I'm not really noticing a budge in my libido, this is something that's really important to me, and I would like to explore other options. I would say a caveat to that, make sure that if you do have any genitourinary symptoms, that those are also treated, because dry, sore vaginas are not going to do wonders for your
Yeah.
desire. And it's really
Yes.
important for blood flow to the vagina, that is looked after as well. And actually that can sometimes be really game changing for women in terms of desire as well. But the main thing would be, if you had that residual symptoms, you are perfectly within your right to ask your GP to consider it. And I mean, lots of NHS formularies at the moment will request that it is a specialist initiated product. How different services are structured varies across the country. So where I work, a couple of our local GPs, and myself included, we run a primary care network hub. So we're able to initiate for our local practices. We're able to advise GPs who might feel confident, perhaps they've done some training. It's not rocket science. There are extremely good, clear guidelines from the British Menopause Society about how we monitor and what to look out for in terms of side effects. So it's a shame it's so hard for women to get, because it can be a really lovely addition for those that need it.
Actually, the side effects is something that we've had a lot of questions about. Can I
Yeah,
ask you
of
a few,
course.
just straight away? First of all, there's a list of questions now, and I know that I've got you on a very short time, so I'll just throw them to you. First of all, the biggest conversation seems to be that people are saying, don't take it because your hair will fall out. True or false?
It very much depends. So I would say that is not a common side effect, but when we're counselling about side effects, we do have to say, it is an androgen. So it's testosterone is we call it an androgen. And for some women that are sensitive to, or perhaps already have male pattern thinning, there is a potential to be cautious when you're prescribing it. Normally, those side effects are when you are sort of supraphysiological. So when we're going outside what a normal female range would be, which is obviously not what we would do. We would monitor so that didn't happen. In women who already have quite a lot of hair thinning, I do err on the side of caution. We go quite slow and steady, and we possibly monitor a little bit more, just to make sure that they're not getting any worsening of that. But no, it's not. It's not a given. It's going to make your hair fall out. For the majority of women, it doesn't do that at all.
Okay, and on the flip side of that, I hear a lot of people saying it makes hair grow all over the
Yeah.
place.
So it is quite normal to have hair growth at the site of application. Some women might notice, if they're having a good response, that they might notice a bit more bodily hair. Again, if you go over levels, then that's when we start to see those sort of more similar to with polycystic ovarian syndrome. When testosterone levels are high, you can get unwanted body hair, possibly some unwanted facial hair. But it's about balancing that against the benefits you're getting, and obviously monitoring to try and minimize any side effects. One of the reasons why we like women to be estrogenized first is that if you have good levels of estrogen, you're less likely to get androgenic side effects. So that's an important factor as well.
So when you're applying it, if it's a cream or if it's a gel, where should we be putting it ideally? What's the best location?
So the two areas I normally recommend are on your pubic, so sort of suprapubic area, because you've got pubic hair there anyway. So if you get a little bit of local hair growth, that's unlikely to bother you. Lots of women who are younger, who maybe have smaller children that are all over them, prefer that it's in an area that they're not going to be having any contact with. Obviously, once it's absorbed, that's unlikely to be an issue, but that can be a concern for some women. The outer thigh is another popular area, and some women put it on the inside of their wrist.
Yes.
So
And is it
all
a
of
different
those,
spot on every application?
not necessarily, but you can do that to mix it up. You just got to try and find something that works for you. I mean, if you're doing it suprapubically, you can just put it wherever. As with all of the transdermals, you need to make sure that you haven't got any product on the skin before. So things, making the skin primed for absorption is really important. I don't think we talk about this enough in clinic. So clean, dry skin.
Yep.
You don't want any moisturizer or SPF or any other creams on the skin before. And then you put it on the skin when it's on in that state, and that kind of thing will really help. Similarly, if you're someone that's prone to quite a lot of dry skin, you might want to include a regular exfoliation into your daily routine or weekly routine, just so that you're not getting that layer of dead skin cells again affecting absorption. All of these little things can sometimes make a difference
huge
in
difference.
how we absorb.
And so yes, actually it's very similar to HRT patches as well,
Yes,
isn't it? Sticking on, not having the lotions on, lotions and potions, and never mix well. Can you just explain a little bit more, because there's a little bit of chatter about private testosterone coming over from Australia, and in the NHS it comes over. It isn't from Australia. It's a male or female hormone. Can you just expand on that a little bit more?
Yeah, of course. So in the UK at the moment, all of the products that are testosterone products that we have are male licensed products. So when we're prescribing them for women, we have to prescribe off-license male products. And there are a few different brands available. In the only female, and that scenario is basically similar globally, unfortunately. The only licensed product for women that exists globally at the moment is a product that's licensed in Australia called Androfem. Androfem you can get through importing it in the private sector. So private menopause clinics are able to do that. It is really expensive. That's the downside. So it's around 90 to £100 for a 3-month standard dosing regime. The challenge we have with some of the male products is, as you know, a lot of the dosing is quite subjective. So, a rough guide is that you're using 1/10 of the male dose. But we're asking women to put on a pea-size amount, for example, of this. So with Testogel, which is the sachet, you say pea-size amount daily, make it last 7 to 8 days. And obviously that's really subjective, isn't it? So I do have some women who think, oh gosh, I've used it all in 5 days, or I haven't used enough and I'm on day 10 and I've still got some left. You do tend to get into the swing of it, but that is a real downside of the products that we have at the moment, and in that kind of area. Whereas with Androfem, it is a cream. You can use it does come with an applicator. You can use the applicator to measure out 0.5 mils, which is normally the starting dose. So there is that benefit. In terms of like for like, there's not really any major comparison studies looking at whether one's better or whether it's still all body identical. I think it's just women do like using a product that's for women.
Funnily enough.
But yeah, and I do have patients that do really well on the ones that we can get on the NHS as well.
Yes, and I think that dosing is something that it definitely needs shouting about, because I know that on Jane's Facebook support group, she's had a lot of women saying, I've put on the whole sachet.
Yes.
And they put the entire sachet on every day, and I mean, God knows where that finishes. Do you just end up with massive beards? Or
well, I mean, it will. Yeah, a lot of the changes, if you do go too high by accident, a lot of the changes are reversible.
Yeah.
There are some very rare changes where we don't know whether they would be fully reversible. So one of the things that we have to counsel women about is lowering of the voice and clitoromegaly, or enlargement of the clitoris. Really, really uncommon, and I do want to stress that. But there, with those sorts of more structural changes, those might be less reversible.
Yeah.
So do really check the dosing guidance when you're given it. And a little tip as well is, when you're having your blood test, on that day, on that morning, if you get a morning blood test, don't put your product on that morning, because sometimes we get contamination and it might just cause confusion. I normally will always repeat a high level, because more often than not, it's just that, a little bit of testosterone has got put where the blood test is going, or they haven't washed their hands properly. And so that can sometimes help in terms of interpreting the results.
Yes, that's a great tip. And Anna, I know that you're diving off, but just one last question. When people are talking about HRT and how long they stay on it, or will I go to the grave with my patch still stuck on my bottom, is testosterone something that we might be on for life? I know that you said that there's a spike and a rise later in life, but might it be something we're on forever?
So the key message message there is that it needs to be personalised, and there are no arbitrary cut-off limits for hormonal replacement therapy. And the British Menopause Society is really clear about that. It's always going to be a conversation, ideally annually, where you're looking at that individual woman and you're looking at her benefits and you're looking at any potential risks, and that will vary depending on her personal background, and you make a shared decision together. So you know, testosterone can be used as part of or as an addition to hormonal replacement therapy for as long as you're on it, and that decision would be something that you would make with your healthcare provider. So yeah, no arbitrary cut-off limits.
Yep, sure. And within the PPC, which is the prepayment certificate for hormone replacement therapy, testosterone's not included, is that right?
Not included at the moment, frustratingly. Yeah. And I think that's probably to do with the fact that it still comes up as a controlled drug on a lot of our formularies. So this is something that I've challenged quite a lot in terms of how we're able to prescribe it in my community hub. It's really frustrating because you know, women aren't going to be using it in a way that's going to put them at harm. They don't want any of those side effects. So it is quite frustrating, and you know, we do just have to keep battling against some of these slightly archaic guidelines.
Yeah. Okay. So this is a conversation that we really need to just keep talking about to try and get that on there. Okay. Anna, I must let you go. I know that you've got patients to see, but for anybody that's watching this, I will put all the links to Dr. Anna Hormones below. Also her Eve Health website, which has got brilliant knowledge center. It's got videos on all sorts of topics, and it's got free resources to read. Also, you do appointments online or in person, and they are within your Westminster clinic, is that right?
Yeah, so I my private practice is in Earls Court, so it's Westminster Women's Clinic, and then if anyone's in the NHS and is in the south of the borough in RBKC, then I'm also there as well. So
well, those lucky people.
Yeah, well, I really, yeah, I mean, I love this part of my job. It's brilliant.
Yeah, well,
so
you're passionate about it, and you know, you're spectacular about honing in on one little bit of subject and blowing it apart and putting it into really simplistic terms, because you know where our starting point is, which is this Google AI. No wonder we're confused.
yeah.
So thank you for advocating for us all. Can we chat another time about
I'd love to.
a myriad of other
Thank you for
subjects?
such a brilliant product, because so many women absolutely adore it, and it's really
Ah.
solved such a simple problem. But you know, we've just been dealing with that sticky glue for ages, and it's really made such a difference. I've got lots of my patients loving it, so thank you.
That's great to hear. It does make it makes people hate the bit that they didn't like about the HRT patches, and usually people love it all apart from the sticky stuff. So hopefully that conversation's shut down.
Yeah.
Which reminds me, I've got to get my sticky off today, which I'll film. But Anna, thanks very much for being with us. Really appreciate it. We'll share this, and for everyone watching, all Anna's information will be shared below. And I hope to see you again.
Yes, I'd love to come back. Thank you.
Thanks, then, Anna. Lots of love.
Bye.
Bye.